Great. Well, thank you. And thank you all for attending tonight. I just want to mention that my co-presenter, Abdullah El-Maroof, will not be able to attend today, so I'll be speaking on his behalf, so you just have me tonight. So I have three main objectives for the presentation. First, I just want to give you an overview of the rationale and evidence for using genotype-guided prescribing, particularly in the child and adolescent mental health setting. And then I also want to give a little bit of background or explain who could most benefit from genotype-guided prescribing. And then I'm going to finish off with some highlights of some current research that we're conducting here in Alberta, examining genotype-guided prescribing, and particularly the implementation of that into clinical care. So I'd like to start off with this quote, and I like this quote because it really challenges some deep-seated perspectives on that there's some drugs that are good and some drugs that are bad. But in fact, every drug is both. It really just depends on the individual who is taking the drug or medication that makes it either a good or bad medication. And so to illustrate this a bit more, I have this figure, and if we look at the population level, we know that medications more or less are efficacious and tolerable. If they weren't, they probably would not be approved by the regulatory bodies such as Health Canada or the FDA. But the problem is we don't treat the population, we treat individuals with medication. And so if I were to take at random someone out of the population, this may look more like this, where we see at the individual level, efficacy and tolerability varies quite a bit. And so our challenge is determining which medication fits in which one of these quadrants for a particular individual. And so in order to do that, we require personalized prescribing strategies. And so I've listed a few here, some of the more common prescribing strategies, personalized strategies that already exist, in addition to genotype-guided prescribing. So liver and kidney functioning, often definitely physicians will always take into account symptoms, the severity of the symptoms, as well as a person's demographics when prescribing. They may use therapeutic drug monitoring, which basically is looking at the blood levels of a particular medication to help advise on dosing. And of course, clinical guidelines that may exist for any particular mental health problem. Now, tonight we'll be focusing specifically on genotype-guided prescribing, but what I want to make clear up front is that genotype-guided prescribing is not meant to replace any of these other strategies, but rather it is actually to be a companion for these other strategies or enhance the use of these other strategies. So what is genotype-guided prescribing? Well, you may have heard it called genotype-guided prescribing, but often it's also termed pharmacogenetics, which is a bit of a mouthful, but it's just the marrying up of pharmacology and genetics into one particular field known as pharmacogenetics. And pharmacogenetics or genotype-guided prescribing basically uses genetic information to predict a person's ability to process and react to medications. Now, we typically lump that genetic information into two broad categories. So we have pharmacodynamics. So pharmacodynamics is basically what a drug does to the body. And so we're looking at genes that are involved in the receptors or ion channels or signaling pathways of these medications or drugs. And the other category is pharmacokinetics, or what the body does to the drug. And so here we're looking at genes that encode things that are to do with how the drug is absorbed, how it's distributed throughout the body, how it's metabolized by the body, and then how it's eliminated by the body. And so currently, when we're talking about genotype-guided prescribing, particularly in the area of mental health, we tend to focus on metabolism. And that's not because we think that the other components here are not important. It's just currently that's where the most research has been done and the evidence sits. So I'll be focusing mainly on metabolism for this talk. So when we think about metabolism in the context of medications, we typically think of drug metabolizing enzymes. And these enzymes, when we think of these enzymes, we typically focus on a particular family of enzymes known as the cytochrome P450 family. And the reason we focus on that is because we know that they're responsible for the metabolism of the majority of the drugs that are available. And so here I've just listed a few of this family of enzymes. And you know they're all the same family because they all start with the CYP, which stands for that cytochrome P450. And then the family name is followed right after it, which is a number, a letter, and another number. And so all of these genes are expressed in the liver. They may also be expressed other places in the body, but the liver is where they do a majority of their work. And I don't have time to go through all of the family, of course, so I'm going to focus on two particular enzymes tonight, CYP2C19 and CYP2D6. Now, I've selected these two for a reason. They're the most important to the metabolism of mental health medications. So collectively, these two enzymes metabolize most antidepressants, about 50% of antipsychotics, and a handful of anti-anxiety or anxiolytic medications, as well as analgesics or pain medications. And so when we're thinking about genotype-guided prescribing, of course, we aren't measuring the enzyme directly. We're using the genetic information to determine how that enzyme is working for a particular individual. And so to do that, we use the genetic information to assign individuals to metabolism groups. And so here's just a little cartoon showing that there's this continuum of metabolism, or what we call enzyme activity. So ranging from individuals that are what we call poor metabolizers, so they have very little enzyme activity or limited activity, all the way up to the ultra rapid metabolizers, so those that have very fast metabolism. And so understanding and knowing where someone falls on this continuum is important because it can help us understand how much of the drug is in their blood if they were given a particular drug. And so this little bar graph under here is just to demonstrate that. So if we gave every single person the same dose, if you were a normal metabolizer, what we'd expect is that that drug level would fall right into this kind of Goldilocks zone, which we call a therapeutic window. So where you're going to get the most therapeutic benefit from the drug, but you're not going to have too much of the drug in your body where you might see side effects. If we would give that same dose to someone that was a poor metabolizer, what we would see is that they overshoot that window. And so they're into this supratherapeutic or toxic range where they're more likely to experience side effects. On the flip side, if we had an ultra rapid metabolizer, they're going to metabolize the drug so fast that they're not going to be able to get up into that therapeutic window. And so they're at higher risk of receiving no benefit from that drug. And then we have the intermediate individuals where they're a little more risk for side effects, and the rapid, which are a little more risk for not a benefit. So it truly is a continuum, and this is what we use in order to predict how someone may respond to a particular medication. So how many children are at risk based on this information or these metabolism groups? So I'm going to tell you about this study later on in the talk, but this is some preliminary data from the work that we've already started here in Alberta, just to show you how many children have what we call actionable genotypes. So these are, but what I mean by actionable is pretty much not normal genotypes, meaning that they may be an intermediate poor ultra rapid metabolizer, meaning that they probably will need some kind of adjustment to the dose of a medication if it's metabolized, in this case, by CYP2D6, that enzyme. In CYP2C19, we see something relatively similar. In this case, we see 43% of children would require some type of adjustment to the medication, or maybe a different medication altogether. And if we look at them collectively, we know that 3 out of 4 children will either have that CYP2D6 actionable genotype or a CYP2C19, or in some cases both. So it's quite a few children, and this also goes to adults as well. It's not just specific to children, but just to give you a little bit of an idea of the prevalence or how often this occurs. So who can really benefit from this? So obviously, if we know how someone metabolizes a particular medication, we will be in a better position to know, well, will someone respond to the normal dose? Will they need a lower dose? Maybe they'll need a higher dose, or maybe they just need a completely different drug. We should stay away from a particular drug. But in order to know which drug and which genes have that strong level of evidence and ready for implementation, we need to go and look at the literature and the evidence base before we start bringing that into the clinical setting. So for genotype-guided prescribing, of course, we're going to look at the scientific literature, the published literature, but it's also important, we also want to look at the drug labels. And that's the reason why we look at drug labels is because the information on drug labels is not always published. So pharmaceutical companies don't always publish all of their data from their clinical trials, but they do have to supply it to the regulators like Health Canada. So we look at both so that we get the full picture of the evidence that exists. Thankfully, we have a what we call the pharmacogenomics knowledge base. So this is a group of researchers and clinicians. They're based at Stanford University. And basically, what they do is they go through all the published literature and the drug labels. They pull out all the evidence, so what we call gene-drug pairs or gene-drug associations. They look at that evidence, they curate it, and then they score it on this scale, the strength of evidence scale. And there's 4 levels of strength of evidence. And so the first is this unsupported, which is basically exactly what it says, that the gene-drug pair doesn't have any evidence at the moment to support any association. Then there's the low-level evidence. This is usually based on a single positive study. So one study has shown that there's an association, but it hasn't been replicated. Or there's been a lot of research on a particular gene-drug pair, but it's conflicting findings. So one study says there's an association, another one says there's not. So there's no consensus. When we get to the moderate level of evidence, we start seeing replications across many studies, but the effect of the association or the strength of that association, some would argue, is not strong enough to make it into the clinic for it to be meaningful clinically. And then finally, we have the high level of evidence where we have those multiple replications, but the effect size is large, and people will, and we would argue that it's ready for the clinic and ready to benefit individuals. And it's this group of gene-drug pairs that fall in that high level of evidence that get moved over into guideline development. And there are 4 main groups that develop guidelines for genotype-guided prescribing. And I've listed them in the order of I guess, rigor. So in the US, there's a big group called the Clinical Pharmacogenomics Implementation Consortium. It's a long mouthful, basically called CPIC for short. And they create a lot of guidelines that are used primarily in North America, but also around the world. There's also a Dutch group where they create similar guidelines, typically used mostly in Europe. And then there's a French and a Canadian group. And here in Canada, we do have this group that does guidelines, but they tend to focus mainly on oncology or cancer drugs. So for mental health, not as much relevance, but still very much active in the area. And so all up, if we look at all of the guidelines that have been developed, there are 82 drugs with guidelines and 23 genes that are implicated with those. And so you can see this is quite a busy figure, But I put it up here just to show you the amount of evidence that exists, and also to show you that it's not just mental health medications, that it does go beyond mental health. So of course we have antipsychotics, antidepressants, we have some ADHD medications, but cardiovascular medications are here. We have anesthetics, pain medications, and so forth. So just to show you that it does span beyond mental health, and it hits pretty much every area of medicine. But of course, we are going to be talking mostly about mental health tonight. And so I've just kind of focused in on the evidence base for mental health medications. And here we have 34 drugs that have guidelines or strong evidence ready for clinical implementation. And you can see right away that those two genes that I mentioned earlier, CYP2D6 and CYP2C19, have the majority of the lines going to them. And as I said, these are collectively, they do the brunt of the work as far as metabolism is concerned, in particular around antidepressants and antipsychotics. So based on all this evidence, last year, the International Society of Psychiatric Genetics developed this consensus recommendation or statement. And basically what they came out and said is that the current evidence does support genotype-guided prescribing for specific antidepressants, antipsychotics, mood stabilizers, and ADHD medication, the one particular ADHD medication, atomoxetine. And I just wanted to show you, now that you kind of have an idea of the evidence and the background of a clinical example of how genotype-guided prescribing can be helpful in the clinic. And so this is a real patient example that was published in the literature several years back. So this was a 23-year-old male. He was presenting with repetitive and obsessive behaviors. He had anxiety related to visual and auditory stimuli, and he was having difficulties with transitions. He was prescribed two medications, quetiapine, which is an antipsychotic, and fluvoxamine, an antidepressant, or more specifically, an SSRI. And on these therapies, he began to exhibit regressive behaviors. And so, most problematic was the aggression. And so his part-time employment was unfortunately terminated, and he was required to return to his family home. And upon returning to his family home, his treating physician did a full workup, including brain scans, CSF analysis, muscle biopsies, and a whole bunch of blood panels. But unfortunately, they found nothing outside the normal range. And so at this point, his psychiatrist recommended genetic testing. And so here I'm providing you just a sample of the results from that testing. And you can see right off the bat, if we look at this, these are the metabolizer groups that we were talking about before for a number of that P450 family. You can see there's no normal metabolizer. So unfortunately, he is a non-normal metabolizer for several enzymes. But I want to bring your attention to one specific one, CYP2D6, and he's a poor metabolizer for this particular enzyme. And the reason I'm bringing focus to that is not just because he's poor metabolizer, but both of these drugs that he was taking are both metabolized primarily by CYP2D6. And so let's unpack this a bit and look at what the evidence and the guidelines have to say about those two drugs and CYP2D6. So first, just to reiterate, both of these drugs are substrates of CYP2D6, meaning they're metabolized by CYP2D6. And I've listed a few other drugs that are also metabolized by CYP2D6. This is not an exhaustive list, but just to give you an idea that there are others. If we look at the drug labels for those two medications, we see for fluvoxamine, not quetiapine, but for fluvoxamine, we see that there are mentions of CYP2D6 on those drug labels. And when we look at the dosing guidelines, specifically the CPIC guidelines, which we use here in North America, for fluvoxamine, it states if you're a poor metabolizer, you may want to consider a 25 to 50% dose reduction or an alternative drug that's not metabolized by CYP2D6. And then when we look at the knowledge base, remember I was telling you about that pharmacogenomic knowledge base and the strength of evidence. If we plot both of these drugs on that strength of evidence for CYP2D6, we see quetiapine fits in this unsupported. So there hasn't been much research on quetiapine. However, there's been an abundance of research with fluvoxamine and CYP2D6, hence the guideline that was developed. And so there is definitely a strong evidence to support this, this recommendation. So in the end, the physician decided to discontinue both of the medications. Now, I just told you that the quetiapine evidence was in that unsupported level of evidence or strength of evidence. But the physician decided to discontinue it anyway because it is metabolized by CYP2D6, and so they were being overly cautious maybe, but cautious and just saying, don't want to prescribe any medications that go through CYP2D6. So instead they switched to olanzapine, which is an antipsychotic, and desvenlafaxine, which is an antidepressant. And it's worth noting that neither of these drugs are metabolized by CYP2D6. So what ended up happening is that this gentleman progressively improved in all those behaviors, and his sleep was improved, and he was able to return to his supported living home and commence work again. And so the take-home message here is that pharmacogenetic testing or genotype-guided prescribing could significantly reduce these types of experiences. And maybe more importantly, that when he returned to his doctor, you remember that they did an abundance of tests, including muscle biopsies and CSF, some pretty intense testing that could maybe have been avoided if the pharmacogenetic testing or the genetic testing was done prior to that. Okay, so some things to consider also when interpreting these test results and putting them into practice is that I don't want you to walk away from this presentation tonight thinking that all I need to know is my genetic and metabolism profile and I can pick the right medication or and go forward with that, because non-genetic factors do have an impact on how we interpret the results. And this is in part due to a phenomenon known as phenoconversion. And so I'm going to explain this a bit. I'm going to have an example. But what phenoconversion is an individual, let's say, is genotyped and predicted to be a normal or let's say an intermediate metabolizer, but clinically they resemble a poor or rapid metabolizer. On the flip side, they could be genotyped and predicted to be a rapid or ultra rapid metabolizer, so a very fast metabolizer, but clinically they resemble more a normal or intermediate or maybe even a poor metabolizer. So I'll give you an example of how this works. So this phenoconversion is due to the presence of inducer or an inhibitor alongside another medication maybe that this person is going to be taking. So for example, let's say we genotype someone for CYP2D6 and the CYP2D6 genotype results predict that they're a normal metabolizer. But we also know that this person is currently taking the antidepressant fluoxetine, which is a strong inhibitor of CYP2D6. So although they are genotyped at a normal metabolizer, because they're taking this strong inhibitor, they actually clinically will resemble a poor metabolizer. So they've been phenoconverted from a normal to a poor metabolizer. And so the opposite can occur as well. So if they were a normal metabolizer and they were taking an inducer, they could go up the scale. So the phenoconversion can go up and down. Just in this example, I'm using the inhibitor. Now, how often does this occur? Well, it occurs more than was previously thought. So this study that demonstrated this quite nicely, there was 900 patients that were being treated for depression. And what they did is they genotyped them. And what they found is genotype alone, 4% of that group would have been predicted to be a poor metabolizer. And that's exactly what we'd expect. About 4 to 5% of the population will be a poor metabolizer. In this population specifically, this was a European population. But what they then did is they said, okay, genetically they're a poor metabolizer. Let's look at what other medications they're taking. And when they did that, what they found is actually 27% would be clinically presenting as a poor metabolizer, or what we call a phenocopy. So they've been phenoconverted to a poor metabolizer. So you can see there's quite a bit of a difference between what the genotype says and what the actual clinical presentation would be. And so this is something that we definitely need to keep into consideration, and why I'm saying that we can't just say, just because the genetic test result says this means we do this. It really needs to take into account other factors. The other consideration that I want to bring up that's germane to particularly in the child and adolescent mental health is developmental factors can affect how children process and react to medications. So I'm using the two genes again that I've been focusing on as an example. And as you can see here on this figure, so this is just showing the enzyme activity. So shortly after birth, both of these enzymes come online quite quickly. So they start to be expressed and they're available in the liver. For CYP2D6, they level off quite a bit. They go right to the adult level. So here's the adult level, and you can see they pretty much level off. And so CYP2D6 is not as much of a concern as far as developmental factors are concerned. However, you can see here for CYP2C19, soon after birth, it spikes. So it's much higher than in the adult levels. So CYP2C19 is more expressed, and it only returns to adult levels in adolescence. And so this is something that also needs to be taken into account, particularly if medications are being used in those early years of life. So typically in children under the age of 10, you may see that someone that's genotyped and determined to be a CYP2C19 normal metabolizer may actually be closer to a rapid metabolizer. And that's because of this increased enzyme activity in early life. So some take-home points from this point forward before I get into some of the research that we're doing. So I have three main points here that I want, if you don't remember anything else, hopefully you remember these 3 points. First is that genotype-guided prescribing is an evidence-based strategy for several commonly used psychotropics, or in other words, mental health medications. They certainly don't cover everything, but like I said, mostly antidepressants, antipsychotics, and a few anti-anxiety and ADHD medications. Genotype-guided prescribing should adhere to available guidelines. So we really want to make sure that we stick to the guidelines that exist. And also, as I mentioned, we really want to consider non-genetic factors. We don't want to get caught into that trap that the genotype is the end-all test. And third, that genotype-guided prescribing, as I mentioned before, is a companion tool that can enhance rather than replace other prescribing strategies. Okay, so now I just want to switch gears a bit and talk about some of the work that we've been doing here in Alberta. And I'm going to start with some of the development work of how we've developed genotype-guided prescribing and how we're still developing it. It's not complete. There's 3 main components or core components to our genotype-guided prescribing strategy. First is our partnerships, and this is extremely important. They basically are the foundation by which we are able to build this from. So we have our operational partnerships with the laboratory, so the Alberta Precision Labs. Those of you in Calgary, it used to be called Calgary Laboratory Services, but now it's Alberta Precision Labs. There's primary care networks, and then Alberta Health Services and their strategic clinical networks. So these are all our operational partnerships. And then we have our funding partnerships, which of course, without funding, it would be very difficult to do any of this or do it in a very rapid way. The second component is the genetic test. So currently our genetic test includes 9 genes, including those 2 genes that I was focusing on, CYP2C19 and CYP2D6. So those are the ones, again, that are most important to the mental health medications. But we include other genes because we're not just focused on mental health, we also want to make sure that the results that we provide can be used throughout the lifespan. So some of these other genes are important for other medications that may come into play for an individual as they age. We use a very specific custom array that we've developed, and then we run it on a machine that's run by the Alberta Precision Laboratories, which is obviously a clinical lab that you would get other testing done that your physician orders. The last component, and truly one of the most important components of this all, is this decision support tool. So we knew early on when we were going into this that many physicians do not have a strong background in genetics, and they're not geneticists. We didn't expect them to be geneticists. So if we were just to provide genetic results without any interpretation, just give it to them and say, okay, here you go, make some prescribing decisions, it probably wouldn't work. So we needed some kind of support tool. And so we developed here in Calgary the sequence to script tool. And so what this does is it takes patient's genetic information. We put that into our tool, which is an algorithm that pulls from a number of databases with recommendations, some of which I just told you about, as well as other databases that can help us deal with that phenoconversion issue. And it puts that all into a recommendations report that is meaningful to clinicians. So it provides recommendations and not just showing them the genetic results. And if you're interested in this, there is a free version of it that we have up on this website. You can play around with it. It's open to anyone. You don't have to be a clinician. It doesn't really matter. It's just if you're interested in how it works, you can do that there. And so this is a bit of a snapshot of our 9 genes and some of the medications that are covered by our test, or some of the medications that are covered. It's not an exhaustive list, but I'm just highlighting a few. Again, we have our mental health medications, of course, but cardiovascular, some of our pain medications, as well as things like PPIs, which are basically for acid reflux. So it covers a wide range of medications, again, not just focused on mental health. One thing I want to note here is that we don't provide recommendations for psychostimulants that are typically used to treat ADHD. So things like Ritalin or methylphenidate, we don't include those recommendations. And the reason for that is not that we have anything against psychostimulants, it's because the evidence base is not to the level where we can provide confident recommendations for those medications. So the only medication that we currently support is atomoxetine for ADHD, which is a non-stimulant treatment. Here's just an example of what the report looks like. So this report was designed with the physician in mind. And so it provides the genetic information, but more importantly, it provides the recommendations. So every report will have a drug or the medication name, the class of that, the gene that's involved with that medication, and then the recommendation, a summary of that recommendation. So in this case, for citalopram, which is an antidepressant, it's saying that this patient's CYP2C19 genotype would suggest we need to consider an alternative drug not predominantly metabolized by CYP2C19, and it provides some examples of other medications that might be more appropriate. It also provides the strength of that recommendation and then the source, where we get the recommendation from. And these are hyperlinked in the PDF report that the physician gets. And the pathway is just if the physician would want to see the metabolized pathway, if they clicked on that, that's what they would they get. We also have a report or a wallet card that we designed specifically for patients and caregivers. And so this folds up into basically a credit card sized card that can be carried around. And it has the genetic information, but more importantly, it has the medications, and it doesn't list the recommendations. We obviously don't have room on the card for that, but it just says which medications may be cautionary. It's not saying that you can't use these medications. It's just saying these medications may have additional considerations. And this is something that patients can take with them. They can show it to their pharmacist or show it to other physicians that may not know that they underwent this testing. And then it has information for the healthcare provider if they want more information. Okay, so with that kind of background and what we've developed, the next thing we want to do is, okay, so we have this infrastructure now. Let's test it out in the real world and let's see how it works. And so this gets into some of our research that we're doing today. And I'm going to focus on two studies that we're doing. The first and our largest study is called PGX Spark, so pharmacogenetic supported prescribing for adults. The primary objective of this study is to implement Canada's first pharmacogenetic testing or genotype-guided prescribing service to improve drug treatment outcomes in children receiving mental health care. So this is focused on mental health, this particular study. And the way it works is once we determine that the child is eligible for the study and they consent, we'll do the genetic testing. We'll ask a whole bunch of information at that baseline, and we'll also get consent to look back 6 months prior to that time at their healthcare utilization and medication information. We'll also then follow them for 6 months, and we follow up with them every month for that 6 months and ask some information as well. And the idea being that we want to see if the genetic testing has made an impact on a number of different outcomes. So to be eligible for this study, we're looking for children that are between the ages of 6 and 17. They have to be starting or changing a psychiatric medication, and preferably the most eligible would be those that are changing or starting an antidepressant or antipsychotic. Like I said before, ADHD medications we don't really support with the exception of atomoxetine. So if that's the main concern, this testing probably is not going to be that applicable. And then we also require that the treating doctor request the testing. And this is important. We don't take self-referrals from patients or caregivers. It needs to come through a doctor. And that's just so that we know that the doctor is aware that testing is occurring and that they're on board for at least looking at the results and hopefully using it to guide future care. We don't have many exclusion criteria. The first is just we have to be able to get some type of DNA sample, so that and that comes from saliva usually, but we can also get it from a swab inside the cheek, a cheek swab. And then we also are excluding anyone that has a history of liver or bone marrow transplant. The reason for that is just that it can cause inconsistencies in our genetic testing results and cause inaccuracies in our results. And so we need to exclude that just for safety reasons. So I just want to give you a bit of an overview of how the process works so you can see how the workflow goes. So again, it starts with the healthcare provider identifying an eligible patient, or a patient saying to their healthcare provider, I think I'm eligible for this and I'd like to get enrolled. Would you refer me? So assuming they are eligible, and they consent, we will then collect saliva, or like I said, a cheek swab, and then the data, we'll collect the pertinent data. We'll then pass on the sample to Alberta Precision Labs, who then performs the genetic test and gives us the genetic data, or generates the genetic data. They pass that on to us, and we prepare the report using that sequence to script decision support tool that I mentioned. And then we pass on the final results and clinical recommendations to the ordering or referring physician, as well as the results in that wallet card that I mentioned to the patient and caregiver. And then at this point, the provider just needs to decide whether or not they would like a consult or not. If they don't need a consult, the recommendations are pretty clear. Then they just move forward with medication selection and dosing. But if they feel like, you know what, I'd like to have a bit more discussion with someone about the results to make sure that I'm understanding them properly. We've partnered with the Alberta Health Services Clinical Pharmacology Consult Service, who can provide those consults and then advise on medication selection and dosing. So this is pretty much in a nutshell what our project looks like. And as I mentioned before, we have just started this. We started in January recruiting, and we have just over, I think, 150, like I said, that have completed this workflow that you see right here. And the goal, obviously, is that we're going to test 6,000 children over the next 5 years. Okay, now the last study that I'm just going to tell you about, it's a bit more targeted, and it's a bit smaller, but this one's called the pharmacogenetics of antidepressant-induced disinhibition. Again, very long title, but we call it PGX-AID. And the purpose of this study is to really understand specifically why 10 to 20% of children who start a SSRI, so a specific type of antidepressant, they experience something we call behavioral disinhibition or activation. And so this usually presents as aggression or agitation, sometimes impulsivity or hyperactivity. And it's very disconcerting for both the child as well as the parents. Unfortunately, although 10 to 20% of children experience this, there are currently no clinical markers or tools to help us identify which children are more likely to experience this. And so we want to use the genotype-guided kind of approach or the pharmacogenomic approach to identify and validate a panel of genetic variants that could be used to identify these or detect children that are at most risk for developing this, this adverse effect. And so I'm not going to go through this workflow. It's a bit busy, but it basically what we're looking for are individuals that that are between the ages of 6 and 17. They have a diagnosis of depression, anxiety disorder, or obsessive compulsive disorder. So we are a bit more specific with this study. We do need those particular diagnoses. And we need someone that has a current or past history of SSRI therapy. Now, we're excluding individuals, again, that can't provide a sample that we can take DNA from, those with a history of liver or bone marrow transplant again. And then we have all these additional exclusion diagnoses. And the reason why we're excluding individuals with ADHD, oppositional defiant disorder conduct, bipolar, psychotic, and pervasive developmental disorder is because many of the symptoms or characteristics of these disorders overlap with the disinhibition or activation syndrome that we're trying to understand. And so it would be difficult for us to tease those apart. And that's the main reason why we're excluding them. So I'll finish off with, I hope I've intrigued you a bit, and if you're interested in these studies, if you're a physician, there's two easy ways to refer here. One is that the patient or family will give you consent to email us their information, and then we'll contact them. Or you can give them our contact information, and they'll contact us, and then we'll take it from there. If you're a patient or family member, these are the ways that we do get referrals. So you just need to talk to your physician and pass this information on. And we don't ask a lot from the physicians. We will ask them to fill out a really brief 2-minute online survey to basically help us tailor that report that we send to them. But it's not too onerous. And like I said, we've had quite a good uptake from the physicians thus far. So I'll finish there. I'm happy to take any questions, and I thank you for your attention.
Great, thank you. We have a question. Is this actually an option here in Alberta right now and covered by AHS?
It is an option in Alberta through the research studies. It's not covered by AHS at the moment. The goal for us is that we show that it's efficacious, that it actually helps patients, and also that it's cost effective. And then that's how we went over AHS. Without those two pieces of information, they're unlikely to cover it as a standard of care kind of testing.
Right. Does the treating doctor need to be psychiatry or a pediatrician or GP?
Yep, can be anyone. We get referrals from all three of those. Yep, it can be. It doesn't matter as long as they're prescribing it's a mental health or psychiatric medication. Doesn't really matter their specialty.
Will adults eventually have access to genotype testing?
Yeah, so we're trying right now to do the same type of study, trying to get funding to do the same type of study with adults. This is probably the number one question I get asked is, my child can get tested, well, I want to get tested. So we are trying to do that. I will say there are commercial companies, there's over 13 in Canada alone that offer this type of testing. There are many caveats to doing commercial testing, of course. And there's a cost to that. So I think the average is about $500 per test, which is quite high for many. So yeah, it is available if you're willing to pay for it, but for free, like we're offering for these studies, unfortunately not yet.
If a child has taken the 23andMe test, can these results be forwarded and used?
So 23andMe at the moment does not include these particular genes that I focused on today. They have told us that they're going to start testing for these genes, but to my knowledge, they have not started testing for them. So unfortunately, I don't think 23andMe data at the moment would be helpful. You'd have to get additional testing.
Do you have a commercial facility you would recommend if the doctor won't participate?
Um, It depends. There are, like I said, there's a number of commercial labs. I'm not willing to say this in a public forum. I don't want to promote any particular commercial test, but I'm happy to take email. If people want to email me and talk to me in private, I'm happy to do that.
All right. Are these studies open already to AHS mental health or able to be open to AHS child and adolescent mental health?
So all of our studies are anyone in Alberta is eligible. So we don't. You just have to be a resident of Alberta and being treated by an Albertan registered physician. That's the only. Yeah, we have people, even though we're based in Calgary, we have referrals coming from Edmonton. And I think we'll probably be starting to get them from Lethbridge as well in the future as the word spreads.
Right. Can you send me that poster, Chad, and I'll send that out to all the participants this evening?
Right. Sorry, I should have done that before.
That's
I forgot
okay.
about that.
That's all right. And you said you'd be willing to take questions if people had questions
Yep.
that you didn't want to answer on this forum? Okay.
About commercial testing, I don't want to promote any particular commercial test in a public forum because it does depend on the specific situation. So
Oh, do you have to travel to Calgary for testing?
nope. So one of the I guess the silver linings of the COVID pandemic is that we originally had our whole workflow in where you did have to be in person, but we took everything online as well as the testing. We mail it to you, and then you mail it back, and we give you the envelopes that you can send it back. So everything can be done remotely.
Wonderful. I think that's the last of the questions. If anybody has any questions that weren't answered, please email them to ces@ahs.ca. Thank you, Dr. Busman, and have a lovely evening.
Thank you.